Good afternoon. Welcome to our Headliners News event at the National Press Club, the place where news happens. I'm Eileen O'Reilly, the president of the National Press Club, a science writer, and the managing editor of Standards and Training at Axios. I wanted to thank our Headliners team co-chairs, Donna Laiwan Leger and Lori Russo, as well as our members, program and event director, Cecily Scott Martin, who helped pull this event together. Today we're going to talk about a very serious topic, doctor burnout, and what is projected to be a serious dearth of physicians. Some are estimating a shortage of 124,000 over the next decade. And this is coming at the worst time. America's healthcare system is near its breaking point as tens of millions of baby boomers soon will become eligible for Medicare, and our nation's chronic disease burden continues to surge. Plus, we're still grappling with the long-term effects from the COVID pandemic, not only with the scientific mysteries surrounding long COVID, but also the growth of mistrust in physicians and medicines like vaccines due to the proliferation of misinformation and disinformation out there. I'm very pleased we have the president of the American Medical Association, Jesse Ehrenfeld, to talk about this serious issue and how it might be addressed. An anesthesiologist from Wisconsin, Dr. Ehrenfeld is the 178th president of AMA, which is the nation's premier physician organization. When he was inaugurated in June of this year, he spoke about health inequities and injustices, and that he would be advocating for the AMA recovery plan for America's physicians. As he mentioned when he was inaugurated, Dr. Ehrenfeld said, quote, "When I am sick, I want to know there is someone helping me who actually cares about me, someone who understands my struggle and my pain, and brings with them the human emotions that are at the center of the patient-physician relationship." Besides being a practicing anesthesiologist, he's the Senior Associate Dean and tenured Professor of Anesthesiology at the Medical College of Wisconsin, where he leads the largest statewide health philanthropy, the Advancing a Healthier Wisconsin Endowment. Dr. Ehrenfeld is also an adjunct professor of anesthesiology and health policy at Vanderbilt University and adjunct professor of surgery at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. A co-author of 22 clinical textbooks, Dr. Ehrenfeld is the editor-in-chief of the Journal of Medical Systems, and his work has been part of hundreds of peer-reviewed manuscripts. Dr. Ehrenfeld is a graduate of Haverford College, the University of Chicago Pritzker School of Medicine, and the Harvard School of Public Health. Outside of his medical career, Dr. Ehrenfeld is an Emmy-nominated photographer and 2015 recipient of the White House News Photographers Association's award for his work in capturing and advocating for the lives of LGBTQ+ people. Dr. Ehrenfeld is a combat veteran who deployed to Afghanistan during both Operation Enduring Freedom and Resolute Support Mission. Phew. I think my first question is going to be, how do you handle all this? It's amazing. We will have a question and answer session after he gives his opening remarks, so please send us your questions as well. Either write them on the cards at your seat and pass them up to me, or send them online as well. And we will get to as many as we have time for. We are looking forward to hearing what he can tell us about what's happening with physician burnout and perhaps what roadmap we can use to begin solving this issue. Let's give Dr. Ehrenfeld a warm National Press Club welcome. Thank you.
Well, thank you, Eileen. It's really a pleasure to be here. There is an insidious crisis going on in medicine today that is having a profound impact on our ability to care for patients, and yet it's not getting the attention it deserves. The crisis is physician burnout. Let me give you 3 quick anecdotes, all very personal to me, that illustrate the problem. 2 years ago, a dear friend of mine, a medical school classmate, an emergency room physician in California who was working tirelessly on the front lines throughout COVID, took his own life. He was an energetic and loving soul, a brilliant, caring doctor who felt the weight of the pandemic on his shoulders. And he struggled to get out from under it. I knew he struggled, but I didn't know how to help him, and he didn't know how to ask for help. I'm still deeply troubled by his death, just as I am haunted knowing that there are thousands of people in his community who can no longer receive his care. More recently, another exceptional physician, a woman whom I personally recruited to lead the LGBTQ health clinic at Vanderbilt University Medical Center, abruptly quit the program. No longer able to cope with the political pressures, the distorted half-truths about the work she was doing. Last week, I was watching her post pictures online, hugging her friends and her colleagues goodbye as she packed up her family to move to another state to practice medicine unfettered by restrictive state laws. Sadly, she's not the first, the last, or the only physician I know who has made the difficult choice to leave a community or a state they love because of legislative overreach in order to practice medicine the way they know it ought to be practiced. And just the other day, I walked into the physician's lounge at the Medical College of Wisconsin in Milwaukee, where I'm an anesthesiologist. And there I saw an experienced colleague who I know well completely break down, so clearly exhausted and overwhelmed. So this is a picture of our healthcare system in 2023. It's not a happy or an uplifting one. Physicians everywhere, across every state, every specialty, continue to carry tremendous burdens that have us frustrated, burned out, and abandoning hope. And increasingly worrying numbers, turning our back to the profession, a profession we've dedicated our lives to. It's estimated that more than 83 million people in the US currently live in areas without sufficient access to a primary care physician. In large parts of Idaho and Mississippi, pregnant women can't find OBGYNs to care for them. 90% of counties in the US are without a pediatric ophthalmologist. 80% are without an infectious disease specialist. More than 1/3 of Black Americans live in cardiology deserts. And in Florida, my own parents lost their primary care physician because the Medicare payment rates for doctors has plummeted over the last 2 decades and pushed many independent physician practices into financial ruin. The physician shortage that we have long feared and warned was on the horizon is here. It's an urgent crisis hitting every corner of this country, urban, rural, with the most direct impact hitting families with high needs and limited means. Imagine walking into an emergency room in your moment of crisis, in desperate need of a physician's care, and finding no one there to take care of you. It's what we're up against. And so while our current physician shortage is already limiting access to care for millions of people, it's about to get much worse. Consider that roughly 2 in 3 doctors admitted to experiencing burnout during the pandemic, according to a survey from the AMA, Mayo Clinic, and Stanford Medicine. That is the highest level of burnout ever recorded by the AMA. Consider that 1 in 5 physicians surveyed during the pandemic said that they plan to leave medicine within the next 2 years, while 1 in 3 said they were going to cut back on their hours. Consider that nearly half of all practicing physicians in the US today are over age 55. And while medical school applications are up, it can take a decade or more to educate and train a physician. Consider that foreign trained physicians, called international medical graduates or IMGs, face enormous obstacles such as immigration and green card delays to practice medicine in the US. Consider that the average young doctor now leaves medical school more than $250,000 in debt, and that huge debt load has implications for our health system, often forcing aspiring physicians to bypass primary care and less populated rural areas in favor of more lucrative specialties in or near large cities. It's no wonder why the American Association of Medical Colleges projects a national physician shortfall of at least 37,000 and possibly well over 100,000 over the next decade. Why is this happening? Ask physicians and they'll tell you. An increasingly impersonal, bureaucratic healthcare system that places enormous administrative hassles and burdens right in our lap each day and leaves us feeling powerless to make meaningful change. Physicians today, on average, spend 2 hours on paperwork for every 1 hour we spend with patients. An attack on science that undermines trust in our medical institutions and too often leads to threats and hostility directed at us and other healthcare workers. Government intrusion into healthcare decisions and aggressive efforts in many states to criminalize care that is supported by science and evidence. Increasing consolidation across all of healthcare that is giving more power to our nation's largest hospitals, health systems, and insurers, and less autonomy and fewer choices to patients and doctors. Widening health disparities for historically marginalized communities by race and gender, between wealthy and low income, people living in urban and rural settings. The twin health crises of firearm violence and drug overdose. And for the last 20 years, a shrinking Medicare reimbursement rate for physicians that has pushed many small, independent practices to the brink of financial collapse and jeopardized care for millions of America's seniors. I want to pause on that last point for just a moment because while physicians understand the financial pain of our current Medicare model, I don't really think the public at large is aware, nor do they know just how much is at stake in our unsustainable Medicare system. When you adjust for inflation, the payment rate for physicians who see Medicare patients has dropped 26% since 2001, which was my first year of medical school, with additional cuts planned next year. 26%. I don't know many businesses in any industry that could withstand a 26% drop in revenue and still survive, much less an industry like ours, which is so essential to the health and well-being of our nation. Meanwhile, we've seen high inflation, rising personnel costs, and increased practice costs that exacerbate these payment cuts. Considering what my colleagues went through during the pandemic, this kind of financial blow is simply unconscionable, and it requires immediate attention from Congress before even more payment reductions kick in at the end of the calendar year. Congress must take action today. Now, why is this an issue for patients to worry about? Because when doctors lack the resources they need to keep their practices open, they close their offices, or they reduce their hours, or they make do with antiquated technology and equipment or fewer support staff. Or they limit the number of new Medicare patients they take, or they just stop seeing Medicare patients altogether. Either way, it's the patients who suffer, especially older adults, those with limited mobility who may lose access to essential care, those who may have to wait months to get an appointment, or who may have to travel much further away to see a doctor that they don't know. As I mentioned, this is the situations my parents faced with their own primary care physician. Now, they're in their 70s. Like many of their age, they have a variety of chronic conditions and some mobility limitations. Too many seniors, like my parents, have gotten the same letter notifying them that their doctor was no longer able to see Medicare patients. This usually leads to a frustrating, frantic search for replacement and too often harm. As delays occur, things get missed in transition, and patients often end up having to travel farther to receive necessary services. And sadly, this is a story that is playing out all over America. It's affecting parents and grandparents, anyone who relies on Medicare for their doctor's care, and all of us who care for them and their well-being. So, how do we fix this? Our nation's physician shortage is complex. That doesn't really lend itself to easy solutions, but it's not hopeless. There are 5 steps that we must take, solutions with bipartisan bills pending in Congress right now that would make a huge difference in our ability to hold on to physicians we have and strengthen our physician workforce so that our nation can better respond to an aging population and the next public health crisis we will eventually face. Step 1 is giving doctors the financial support they so desperately need to take care of us. This is critical for our colleagues in private practice that are the backbone of our nation's healthcare system, reaching millions of Americans in rural communities whose health often suffers because they already lack access to care and have few options if the local physician closes down. We need Congress to pass the bipartisan bill that was introduced in the House of Representatives earlier this year, the Strengthening Medicare for Patients and Providers Act. It's H.R. 2474, which would do what the AMA has long advocated for: provide physicians with an annual payment update to account for practice cost inflations, as reflected in the Medicare Economic Index. This would simply put physicians on equal footing as inpatient and outpatient hospitals, skilled nursing facilities, and others who receive payment through Medicare. We need Congress to pass meaningful Medicare payment reform. That step is simply essential. Step 2 is reducing administrative burdens, like the overused, inefficient prior authorization process that insurers use to try to control costs. Physicians and their staff spend an average of 2 business days a week completing prior authorization paperwork, including submissions and appeals when insurers inappropriately deny care for treatments often already in wide use. This onerous process not only frustrates doctors and drives up healthcare costs, it's just downright demoralizing for patients. Nearly 80% of physicians in one AMA survey said that they've had patients abandon treatment due to prior authorization struggles with insurers. 2/3 said that authorization delays led to additional office visits, another factor that drives up costs. This issue also lies in the hands of Congress with the bipartisan Improving Seniors' Timely Access to Care Act, which would expand prior authorization reforms that were finalized by CMS. It's also in the hands of the Biden administration, which can significantly improve the prior authorization landscape if it finalizes proposed regulations. And in the hands of state legislatures, many of which are considering their own reform measures. About a dozen states have already passed comprehensive prior authorization reforms this year, many based on AMA model bills, but much more needs to happen. Reforming our antiquated Medicare payment system and fixing the broken prior authorization processes are 2 pillars of our AMA recovery plan for America's physicians that we released last year, and really which remains the focus of our state and federal advocacy efforts. Step 3 in addressing our physician shortfall is securing passage in Congress of 3 bipartisan bills that seek to expand residency training options, provide greater student loan support, and create a smoother pathway for foreign-trained physicians who already comprise about 1/4 of our nation's physician workforce. This is particularly important to address shortages in medically underserved areas of the country. The AMA supports the Conrad 30 and Physician Access Reauthorization Act bills, now in Congress, which would make necessary improvements to the J-1 visa waiver programs to address physician shortages, especially in rural and underserved areas, but also promote a more diversified workforce. The Conrad 30 bill also provides greater worker protections to prevent doctors from being mistreated. We also strongly support the Healthcare Workforce Resilience Act, which would recapture 15,000 unused employment-based physician immigrant visas and the Retirement Parity for Student Loan Act, which allows retirement plans to make voluntary matching contributions to physicians during residency, as well as the Physician Shortage GME Cap Flex Act, which would expand residency training programs in primary care or other specialties that are facing shortages. Step 4 is to stop criminalizing healthcare. Healthcare that is widely recognized as safe, healthcare that is backed by science and many years of evidence. Now, predictably, the U.S. Supreme Court's decision last year to overturn Roe versus Wade has radically changed the healthcare landscape in America, both for patients and for physicians. 14 states have enacted outright bans on abortion, and 7 others have enacted partial bans. Unrelated to the SCOTUS decision, but just as damaging, 22 states have enacted laws restricting or banning gender-affirming care. Let me be clear. These efforts, fueled by misinformation and a heated attack on science and evidence-based care, have forced government into the most intimate and difficult decisions a person can make. They have sown confusion for physicians and patients and opened deep political rifts between neighboring states. They have made physicians and other healthcare workers the targets of attacks and intimidation. They have caused aspiring young physicians to reconsider where they will attend medical school and where they will ultimately practice. And they have needlessly jeopardized the health of millions of Americans. Step 5 is making sure that physicians aren't punished for taking care of their own mental health needs. Every physician I know has a friend or a colleague affected by burnout, or has themselves confronted symptoms of emotional exhaustion or detachment from their work. Physicians, in fact, die by suicide at twice the rate of the general population, an alarming statistic that puts my classmates' struggles into context. Now, it's important to say that not all feelings of professional burnout lead to thoughts of suicide, but the fallout can still have widespread and lasting repercussions for doctors and patients alike. The roots of physician burnout go much deeper than the everyday frustrations we all experience, and instead point to systemic issues in our healthcare system that are highlighted in a recovery plan for physicians. What's worse is that physicians are often reluctant to seek help for their own mental health over fears it will jeopardize their license or employment because of outdated, stigmatizing language on medical board and health system application forms that ask about a past diagnosis. In fact, 4 out of 10 physicians in a recent Medscape survey said they have not sought mental health treatment. 4 out of 10, because they worry about their medical board or their employer finding out and potential repercussions. Seeking therapeutic interventions early helps protect against crisis situations later. So, while the AMA and others are pushing for legislative fix to address the drivers of burnout, while we're working in collaboration with national medical licensing and credentialing organizations on this issue, we're also urging states and physician employers to audit their own licensing and credentialing applications to remove questions that ask about a past diagnosis of a mental illness or substance use disorder or past counseling to help with one. In its place, we encourage boards and hospitals and systems to focus on whether a current health condition, such as depression, exists, that if left untreated, would affect patient safety. And once outdated language is changed, we must be intentional about promoting these revisions far and wide so that physicians know it's safe to prioritize their own mental health. Seeking care for burnout, mental illness, or a substance use disorder is a sign of strength, an act that takes courage and deserves our health system's unconditional support. And in fact, the health of our patients, our nation, depends more on physicians seeking mental health for their well-being before they abandon medicine altogether. Our nation's physician shortage is not a problem to just set aside and deal with tomorrow. It is an urgent problem that we need to address today. We must take action to create a stronger, a more resilient physician workforce to care for an ever-changing nation. And we must ensure that you, me, and everyone else in America has a physician to care for them or a parent or a family member in their time of need. Most of these solutions have bills pending in Congress with strong bipartisan support and momentum growing in many states to put other safeguards in place. There isn't much that our two major political parties see eye to eye on right now, but on these issues they do. We just need the will and the urgency, perhaps a speaker, to get it done. We need leaders in Congress to step forward and make this happen. Sadly, every day we wait, the size of this public health crisis grows. We need action today. Thank you so much for having me.
Thank you.
Yeah,
I'm sorry to hear about your friend.
thank you.
So just picking up on what you just mentioned, how much, with what Congress is going through right now, how damaging is that to, getting these things passed and out there?
Well, certainly we need congressional action. If we don't get something done by the end of the calendar year, there'll be another 3.36% cut to Medicare payments for physicians, which will be devastating. Mm-hmm. So again, there is, I think, shared agreement across the aisle that there needs to be action, there needs to be a vehicle, we need to do this. And there's bipartisan support for a lot of these bills and all of the solutions. We're optimistic that they can get it done, but obviously we need to make sure that they have the capacity to bring bills forward and get things passed.
Yeah. Okay. So we got a lot of questions from the audience, which is great. Okay, a medical graduate asks, they said, state legislators I have talked with have said they are interested in granting provisional licenses for those who have been unmatched and can work under the supervision of board-certified doctors. What is your take on that?
So the AMA has clear policy on this.
Okay.
We believe in the importance of having a graduate medical education in order to practice medicine. Those decisions are obviously left to the states in terms of what the licensure process looks like. Mm-hmm. But our approach is that we need to expand the GME slots, which unfortunately have not really budged in 25 years.
Wow.
Because the dollars that support training positions are tied to Medicare funding, and since the 90s, basically, it's been frozen. We had a little bit of a bump 2 years ago, another 1,000 spots. We need 14,000 spots. We need 20,000 spots, not just another 1,000 to solve this problem. That is the solution that we need, not some of these other options.
Okay. And is that in one of the bills you were talking about?
It is, yes.
Okay. Which one is that?
It's the, I'll have to get back to you on
Okay.
it. It's the, there's two vehicles. One would add, I think it's 2,000 positions every year for 7 years to get us another 14,000 spots. Okay. There are a couple of different flavors of it. But again, people know we need to do this. Mm-hmm. We just, again, need Congress to push the bills forward.
Okay. Someone asks, is physician burnout unique to the U.S. medical system, and do you see it to the same extent in the U.S. or other countries with national health programs?
I don't have data from other countries, but in my role as AMA president, mm-hmm. I get to interact with my colleagues around the globe. Mm-hmm. And we work with the World Medical Association. It brings together 115 nations, my counterparts, and we actually get together in person twice a year to talk about policies. And what I do hear is that burnout is real in other nations all across the globe. And what I do hear is that other countries are having similar workforce issues. And you need to remember that 25% of practicing doctors in the US came from other countries. So we benefit from what is happening in other systems in terms of their training systems and programs. We have to work together. Ultimately, it's a zero-sum game, but certainly those pressures do exist in other places.
Mm-hmm. And do you know, are other countries facing the same mental health issues that we are?
I don't know, again, statistically what those rates look like in terms of burnout because I just don't have at the tip of my finger what those survey data look like. But I know that the toll of COVID, the exhaustion, the pressures are not unique to the United States.
Yeah, and that was a related thing is I know journalists also face this issue as far as the diminishing trust in our institutions.
Yeah.
How do you think we should, fix that?
It's a challenge.
Yeah.
So we certainly are, I think, going to be dealing with the legacy of the pandemic, which is lasting, which is this crisis of misinformation. And unfortunately, it's leading people to make bad choices.
Yeah.
We have not seen the kind of vaccination uptake that we'd like to see. I am getting my vaccine, my updated COVID booster on Monday.
Excellent.
Everybody else should too. It's really important. It's one of the best things that you can do, along with seasonal flu and other things. But misinformation, unfortunately, continues to swirl around online. We have called on media companies to do their part. We need credible media outlets to do their part to lift up credible stories, to help their readers understand what is evidence-based science, what is factual information, but it's something that's not going away anytime soon. I had the privilege of talking with Tony Fauci about a year and a half ago at a meeting, and he said, Jesse, we just have to turn it up to 11 and make sure that we are not letting these other voices drown out what we know is science-based medicine.
So how do you feel today's volatile political environment is contributing to physician burnout?
So certainly, I think we live in a nation that is divided. But at the core, people who join the profession, people who dedicate their lives to medicine, always put their patients first. And so, the great thing about the AMA, we bring together 190 state and specialty societies twice a year to have very vigorous open debates about what we should do. And we have physicians from all over the country with various perspectives. The beautiful, I think, very special part of our process is that people bring their best arguments forward, and they, again, come at this from all sorts of angles. We vote, we set our policy, and then we go out to dinner. And I wish that happened more here in Washington, D.C., where there was that sense of camaraderie and sense to put the mission first. And I have a military background. I'm very much about trying to make sure that we execute the mission and putting mission above self. And I see that in our association. I see that in physicians. Unfortunately, we've got all this background noise that is making it more challenging.
Do you work with doctors in the military?
So I spent 10 years as a Navy physician, very proud of that. Got to deploy overseas in 2014, 2015. I still have an adjunct appointment at the Uniformed Services University. And so certainly we have great representation within the AMA from the military physician community. All of the services are represented by their respective surgeon generals, service surgeon generals, or a designee.
Are they dealing with different issues than the general physician population?
They're very similar.
Okay.
And we actually had a really, I think, seminal call right after I took office in June with senior leadership within the military health system about workforce challenges, burnout challenges, and things like those. They have different issues because the prior authorization challenges and the billing issues don't really exist to the same degree in the DoD system. But everybody is squeezed, and there are lots of challenges that we definitely find opportunities to partner on.
Somebody writes, pharma has been flooding the airwaves with ads blaming pharmacy benefit managers for the high price of drugs. Who, in your opinion, is to blame for the high price of medicines?
So certainly if we had more transparency around what the PBMs are doing, we believe it would help us reduce overall costs. And so there is definitely a lot of finger pointing going on. And one of the things that we do think would be helpful would be to have more competition in the marketplace. As you know, there's been a lot of consolidation. There are a handful of PBMs that really drive a lot of the market share, and more transparency about what they're doing, how these rebate programs are working or not working would certainly be helpful to patients and consumers.
Let's see. In the past year, we've seen healthcare workers go on strike. Recently, Kaiser Permanente and a coalition of unions reached a deal to address staffing shortages and lagging wages after thousands of nurses, ER technicians, and pharmacists went on strike. This speaks of a larger issue. Is our healthcare system broken?
We have a healthcare system in crisis, and those pressures get manifested in all sorts of different ways. Certainly, labor actions is one of them, and we know that we can do better. We know that we can provide more resources. We can provide things that make it easier for people to practice medicine. I did not go to medical school to click buttons on my computer and not talk to my patients, and yet increasingly that's what people do, and it's frustrating for the average primary care doctor that spends less than half of their time actually in front of a patient, talking to them, learning about them, trying to help them and their family, instead doing all these things that are really administrative waste and don't add value to the system.
Can generative AI or AI in general help out with that issue? And what are your thoughts about that?
Sure, if done in the right way.
Right.
And I'm board certified in informatics and anesthesiology, so I am a big believer in technology, but we have to have technologies that work for doctors and for patients. And unfortunately, I lived through the rollout of electronic health records, paid for and incentivized by your tax dollars. That was a bumpy road. And the reason it was bumpy was the systems were not usable. They were not designed to meet our workflows. And we had a disconnect between these technologies and what people actually needed. There is a way to make these technologies, AI, software as a medical device, digital therapeutics, an asset, not a burden. It requires the voice of the physician being present throughout the design and the development cycle. And the AMA is deeply engaged in this. We have something called the Physician Innovation Network. It's an online platform. It's free. It's open to anybody. Developers, entrepreneurs, physicians, nurses, students, residents can all come together to work on solutions collaboratively. And we've seen companies bring clinical voices forward through that format and get to the market quicker with solutions that we think are better. And that's one aspect that we know certainly will help. I'm a big believer in these technologies. I think we are at the height of the AI hype cycle. You can't go an hour without talking about ChatGPT or large language models. I think people don't really understand what they are, but I'm certainly enthusiastic and expect that they will certainly change how we deliver care at some point in the future.
Where do you see it, first being approved in?
So 20% of US practices use AI today.
Okay.
And that surprises people. We do these serial tracking surveys, digital medicine, and health tools. But it's the unsexy stuff. It's back-end office operations, it's supply chain management, it's scheduling. The more exciting applications, I think, for doctors and patients are these sort of clinical decision support tools. Places where we actually have an opportunity to use AI to augment the capabilities of our providers, physicians, and expand what people can do. I'll give you a quick example. The first autonomous AI-approved device by the FDA is in the diabetic retinopathy space. So every patient with diabetes needs an annual eye exam. It's important because if we detect diabetic retinopathy, we can treat it, try to prevent it from leading to blindness, which is a devastating complication. We do not have enough ophthalmologists to screen every diabetic patient in America. Just doesn't happen. We will never have enough. There is a little box, it's about this big, that you can put in a retail pharmacy, you can put it in a primary care office, you can put it anywhere you want. A high school educated operator can put a patient in front of it, take pictures of the retinas, and the AI is so good, the image recognition is so good, the company carries malpractice insurance on the device. Suddenly, you can screen millions of patients overnight, right, with this device. And then the ophthalmologist only has to see the patients with the disease. It changes the workflow. It augments the capabilities. It scales the capacity of the workforce. And those kinds of tools, I think, are really exciting and where AI is going to make a big difference.
That's exciting, yeah. How about a role for healthcare technology in solving physician burnout or shortage problems? Especially the burnout. Like, there's a lot of new mental health tools out there. Is that something you think is helpful, or?
There are great solutions out there. There's apps, there's online things. I think at the end of the day, we need to reduce the stigma so that people are willing to use these tools. There is so much fear. I will tell you, I had another physician colleague in my office who went into an acute psychotic crisis. And I walked that colleague to our employee assistance program. And the first question he asked was, what does this mean for my job? And concerns about confidentiality, stigma, employment, they're real. And it's why that Medscape survey is so frightening that 4 in 10 people say, I know I need the help, but I'm afraid to get it. So you can have all the tools out there in the world, whether they're digital, in person, new or not. If people don't feel safe accessing the care that they need to take care of themselves, they're not going to use it.
I know that a lot of people have said that they felt the pandemic actually helped regular civilians, prioritize their mental health and well-being more. Do you think that's true with doctors, or is that not quite.
I don't know. I think there are a lot of concerns about the social isolation that was happening
Yeah.
in the first kind of phase of the pandemic, and certainly we've seen that impact on kids in schools, and we're trying to understand what that means and how we create social connectedness. I don't know really, what those differences are in the physician population. I'm not sure that we have the data.
Right, that makes sense. Let's see, what else? Okay. Becoming a doctor is expensive,
It
as you
is.
mentioned. Many doctors graduate 100 or thousands in dollars of debt. How does that contribute to the problem? If you want to talk a little bit more about that.
Yeah, so it's pretty simple. First of all, there are a lot of amazing students in high school and college who see the price tag of going to medical school and say, there's no way I can do this, particularly from under-resourced communities, historically marginalized communities. That has an impact on who's going into medicine. And we need a diverse workforce. Why? There's an equity component, but we also know that patients do better when we have diverse healthcare teams. So it's really, really important. And unfortunately, it drives specialty choice. It drives where people practice. And there are tools that we know can make a difference around how loans accrue and how interest is handled and how we're able to contribute to retirement plans during residency or not, that ultimately could make these pathways more accessible to a broader range of students and also open up specialty choice and practice location to more people.
You talked about a significant drop in Medicare reimbursements that physicians have experienced over the last 20 years. How was this allowed to happen? What are the prospects for fixing it when Congress is so divided?
Well, I'm not going to point the finger at anybody in Congress or any piece of legislation that led to it, but it is a funny artifact of how the system has been set up and reconfigured over the years. And the fact that there was just never built in an inflation adjustment, I don't know if it was intentional, accidental, an omission, but it's having this devastating impact that we have seen reimbursement rates just not keep up with inflation, and obviously practice costs continue to go up. And we have seen obviously record levels of inflation this past year that's just made it harder. And that's why so many health systems are in the red, margins have gone away, and it's been increasingly challenging to keep services going.
Yeah, it's been tough. Okay. The AMA also encourages state legislation to protect physicians seeking help for wellness, burnout, and fatigue. Can you talk more about this and where you see it actually working and where?
Yeah, so I wish every state had a confidential
Yeah.
place for physicians to go and other healthcare workers when they need help. That doesn't exist. And so we're trying to encourage more and more states to create that safe haven so that their license is not put in jeopardy, so that there is a funded place where there are resources and support. And again, I gave that example of my colleague who ended up using services at our hospital where I was working at the time. A lot of physicians are afraid to go get those services where they work because they're worried about confidentiality. If you work in a small system, a small clinic, a small hospital, and it's your colleague who's providing the care that you know and work with, obviously that creates a difficult situation. So having physician health programs that are funded and resourced and available in every state with the legal protections around them is a critical tool that we would love to see more states take up.
Mm-hmm. What kind of, what does that look like in the states where it is?
Yeah, so there are a couple of really great examples.
Yeah.
Massachusetts has a really great one I happen to know because I trained there, where there is an independent entity that is funded to provide services for physicians who need mental health services, substance use services, treatment, mental health counseling, and a lot of times they're very structured programs. There is a National Association of Physician Health Programs that tries to support the creation of these where they don't exist in certain states and shore up the ones that do. But there is a clear model. It works well. We know that physicians who have used those services have been able to continue practice, re-enter practice very successfully, and obviously that is an important component of the workforce equation.
As you described in your remarks, we have an aging population with a physician shortage projected to worsen. What are the obstacles to bolstering our physician workforce? What pushback are you encountering?
Well, we have grown the number of medical schools. We've had dozens more come online in the last 10 years. Some have increased their enrollment, so we've got more and more students, which is great. but we don't have the places to train them. And you don't just go to medical school and you go out and practice. You need to have a residency. You need to go through graduate medical education and potentially specialize or go into primary care. And unfortunately, we have more and more qualified students every year who would love to have a training spot. And we turn them away because we haven't expanded GME fast enough to keep up with the demands of the population. We have more and more international physician graduates who would love to come and train in the U.S. and stay here, and yet we don't have that capacity. And unfortunately, right now, unless we get more adjusted with the J1 visa waiver problem, we train all of these international physicians, and then we tell them, go home for 2 years, and then come back and practice, which makes no sense after we've made this investment in getting them trained up.
That doesn't make any sense.
It doesn't, but we can fix that. There's a bill.
There we go. Let's see. Okay. Can you talk a little bit more about, why physicians are reluctant to sometimes seek help? We found during the pandemic that, they're no different than any other person and are facing even stronger pressures in many cases. I know you said that they were concerned about their jobs, but is there a way to make that a better system?
Yeah, I mean, look, there is tremendous stigma around mental health in America.
Yeah.
That is not news to anybody. We continue to be disappointed that third-party payers have not ever executed on what should be mental health parity between medical services and behavioral health services. That's why there's some pending legislation that would potentially address that we think is important. And again, that goes back to stigma, deprioritizing behavioral health, mental health, as opposed to physical health. And I will tell you, a lot of doctors just don't put themselves first. We need to help people understand that it's okay to get the help that you need. But that takes courage. It requires systems changes. It requires us making sure that people feel safe.
Yeah. You talked a little bit about the Dobbs decision and how it's affected healthcare across the nation. I've heard that has affected, affected many different parts of medicine and medical care. What can we do to help people that live there, that want more coverage, or?
Well, it's confusing,
Yeah.
and I hear story after story after story
Yeah.
of physicians who are, their first call now is to the attorney to say,
Right.
can I do this, which is crazy. If you have a kid who needs help with their diabetes, you call a pediatric endocrinologist. If you have a child who has a respiratory problem or asthma, you might call a pediatric pulmonologist.
Right.
To have to call an attorney when you have a woman who is bleeding from a malimplanted pregnancy is crazy.
Right.
And yet that's kind of where we are right now. So we have tried to support physicians in every state to just understand what they can and can't do to make sure that they can put their patients' needs first, but still play by the rules of the laws that they're working in. But unfortunately, it's led to a reduction in access, particularly to women's health care in many jurisdictions, because people are leaving and saying that they can't provide comprehensive care, and so they close up their practices, and that's obviously impacting all of women's health, not just women who need an abortion.
Right. Yeah. Thank you. Latino doctors represent just 6% of all physicians. Many other groups experience similar underrepresentation. How do we increase the number of Latino doctors and from other groups as well?
Yeah, it's a really important issue, and unfortunately we got a blow this summer with the Supreme Court decision that basically has functionally ended affirmative action in higher education, and the AMA stood against that decision. We were part of an amicus brief with the Association of American Medical Colleges, and unfortunately we don't know what the fallout's going to be. We had been making small gains in terms of getting Hispanic, Black, other underrepresented students into medical schools and into training programs. I worry greatly about what this is going to mean for students coming into college and students going into medical schools. And so we're working very closely through our Accelerating Change in Medical Education program, which brings together medical schools and GME sponsors from across the country to try to navigate some of these challenging issues. But there aren't easy answers.
Yeah. That's been part of the problem with trust in doctors, right? Is that some of the communities don't see representation and they don't feel as comfortable reaching out and that type of thing, right?
Yeah, I mean, there are a lot of issues
Yeah.
that have slowly eroded some of that trust, but certainly from historically marginalized communities, certainly there have been incidents over the years that have eliminated that trust. And so it's no wonder that when we have mistreated a population, we have experimented on a population, that a population says, well, why would I trust the medical system? And so having more doctors from those communities certainly is an important component of trying to restore and rebuild that trust. But that's going to be a challenge with some of these restrictions that now have come from the Supreme Court decision on affirmative action.
Yeah. So I know in 2022, the AMA found the highest percentages of burnout occurred among 6 specialties: emergency medicine, hospital medicine, family medicine, pediatrics, obstetrics, and gynecology, and internal medicine. Why do you think those are the ones facing the highest burnout?
Yeah, so there's so much pressure on primary care right now that I'm not surprised that our primary care specialties are on that list: pediatrics, OBGYN, family medicine. So much pressure on folks at the front lines in the emergency departments because lingering issues with COVID and spikes and surges and all those kinds of things. But what happens when people don't have access to a primary care doctor?
Right.
They go to the emergency department. And unfortunately, that pressure, that frustration has all sorts of cascading impacts on those physicians, and the things I think are very interrelated.
Okay. So we talked a lot about many of the issues that are facing doctors and physicians and people needing healthcare. What brings you, this is the last question, so what brings you hope now? Like, what is a positive thing you see happening that you think will be?
Well, I'm the ever optimist, and it's good because I'm early still in my career, and I got a lot of runway and a lot of years ahead of me seeing patients, which excites me. But on Monday I'm going to get my COVID booster. I'm going to put on my scrubs, and I'm going to go take care of patients in the operating room. And when I walk into the hospital, which happens every time, I see my colleagues putting on their scrubs and their white coat, showing up for their patients, in spite of all of these enormous challenges, in spite of all of the obstacles and the frustrations and the wanting to bang your head against the wall because another insurance company has denied something that should be obviously approved. In spite of that, people show up and do the work. And I know that we continue to have people coming into the profession who do it for the right reasons because they care about healing the nation and taking care of their patients. And I think as long as we continue to do that, regardless of what's ahead, we will have people who are there to take care of our patients.
Well, great. Well, thank you so much for sharing all your insights and experiences and knowledge, and keep up the good fight. So thanks.
Thank you for having me.
Of course. Okay.